Gun. Optometry is like a box of chocolate. You never know what you're going to get. Because the next piece, you never know what kind of patient you're going to see. In my office, does anybody know what gomos and tychos are? Okay. Gomos, I like seeing these patients. My partner doesn't like seeing these patients. A gomo is get out of my office. A tycho, what is tycho? You got it. Don't even take your coat off. And those are the type of patients that you'll see right now. Okay, that was not good. Here we go. All right, clinical presentation. A 50-year-old female comes in complaining of diplopia. Tell me what you see there. Okay, come. Tell me a little louder. Which eye are we concerned about, the right eye or the left eye?
The right eye.
Okay, let's vote on it. Are we concerned about the left eye? Who raise your hand? Okay. Are we concerned about the right eye? Raise your hand. All right, I'm concerned about the right eye. I'm concerned about both eyes. But I'm concerned about the right eye. What is the difference between the right eye and the left eye here? Exactly. The right eye is proptotic. The right eye is sticking out. If you look over here, the right eye is sticking out, the left eye is sunken back in again. And when we ask the patient to look at the specific lateral gaze, this eye can move fully and this eye can't move to the lateral position, or it can't move up as well. So far we have a proptotic eye, and so far we have an eye that can't move fully to one side. So where do you think we're going on this one?
Syndrome.
Thyroid. Okay, that's one very good guess. On this particular instance, we're not going thyroid. But yes, the proptotic eye. The reason why I would think not would be because with the thyroid problem, you would probably have bilateral proptosis. You would have both eyes. Yes. So we have unilateral proptosis here. We have extraocular muscle restriction. We have diplopia. We have 20/20 bilaterally. We have increased hyperopia of one eye. Why would we have increased hyperopia of one eye?
Because the tumor is pressing on it and making it smaller.
Okay, but the eye is shortening a little bit. But why would the eye be shortening a little bit? A tumor is pushing in from the other side. It was about a 1 diopter shift, not in the right eye, not the left eye. Once again, here's a close-up. Here's the optic nerve. And here's the optic nerve of the right eye. Here's the optic nerve of the left eye. And here's the optic nerve of the right eye. What do we see in the optic nerve of the right eye? Blurred disc margin. Why would we see a blurred disc margin? Because once again, something is pushing in from the outside. And here we have, once again, we have a fundus camera, but I actually took this camera with a slit lamp and a 90 diopter lens. Here we compare, we have a nice distinct border. Here we compare, we have the swollen nerve head. What did I do? I referred to the neuro-ophthalmologist. He ordered an MRI. He ordered a CT scan. This is the tumor. This is the eyeball. It's in reverse. This is the eyeball. This may be another eyeball, but it's not. That's why the person sees nothing, because they have two eyeballs on the right side. But this is the eyeball. This is the tumor. It's a hemangioma. A hemangioma is a tumor of the blood vessels. It's benign. However, it has to be removed. So here we have another picture of it, another view of it. So you can actually see the blood vessels inside the tumor. It's pushing on the medial rectus muscle. That's why you're having a restriction of gaze. It's pushing in the posterior aspect of the globe. That's why you're having an increase in the hyperopia, a +1 hyperopia. And it's also impinging upon the optic nerve. So we have what's called a cavernous hemangioma. It's a painless proptosis, no pain at all. However, she sees double. It's benign. It's usually inside the muscle cone. In other words, you have the extraocular muscles, the 4 extraocular muscles, they form like a cone, so it's called an intraconal. It's an abnormal buildup in tumor of the blood vessels. Estrogen may increase its size. It could be there from the time the person's very young, but as the person gets a little older, a female gets a little older, the hormones can change, and as the estrogen increases, it can increase in size. It can compromise optic nerve function, and it's more common in women because it is estrogen-driven. Well, she has a choice now. She has to have it removed, correct? Otherwise, it's going to completely compromise the vision. So it's a vascular tumor, it's painless, it's a compressive optic neuropathy, induced hyperopia, possible strabismus, increase of intraocular pressure, because if it's decreasing the size of the globe. It can cause chorioretinal folds, because once again it's pushing on the retina. It might enlarge during pregnancy. So we have two ways of, not we, but the surgeon has two ways of dealing with it. One way of dealing with it is remove it, surgical excision, and they call it, if they remove it this way here, it's called a lateral orbitotomy, where laterally you take away some of the skull and you pull the tumor out. Or you can do it anteriorly like this. Now in this particular instance, I'll show you in a second which one was chosen. In this particular instance, don't forget the tumor was a little bit medial. So therefore, if you pulled it out, you had to go across the entire globe. You had to go across the optic nerve. So this is what happened. They chose it to do it the anterior approach or the lateral orbitotomy, and they chose, which one was chosen? The anterior approach. However, when they took out the tumor anteriorly, they also cut the levator. Now that's a help. It's okay, we fix the levator, sweetie. Actually, she just said, to hell with the surgeon. Okay. So, she was not a happy camper on this one. So it cut the levator, so what couldn't she do anymore? She couldn't open her eye anymore. Not a happy camper. I'm not a happy camper. I didn't do it, but I'm not a happy camper for her. Very nice lady. So what happened? Was there third nerve damage? There wasn't third nerve damage because there's no restriction of the ocular muscles once the tumor has been removed. The pupils are reacting quite well. Is there levator damage? Absolutely, there's levator damage, and they have to reattach the levator. So then she underwent a surgery where they tried to reattach the levator, and now she can't close her eye. So, hey, 6 of one, half a dozen of the other. So she can't close her eye now. Not now, this was in 2008, and this is the way she looked in 2008, because this is before one of my lectures in Israel. I always call her to come and take pictures, so she always gets dressed up and comes and takes a picture there. And then she had, her cornea looked terrible, because her cornea was completely dry because she couldn't close her eye. So she would use ointment at night, and she had keratitis sicca, and she leg ophthalmos, and it wasn't very good. Now she had another surgical procedure to correct it. And you see this little scar over here, this little scar over here, this over here as well. That's characteristic. Are you losing here? That's characteristic of a specific procedure, and that's called an eyelid sling. And you can see the scar here, and the scar here. And this is what a cornea looked like. It's really very, very dry and a lot of staining on the cornea. So what they do is they put a tutoplast fasciolata sling. To me it sounds like a fancy coffee. I don't drink coffee, but I would love to walk into a place and say, I'd have like a tutoplast fasciolata, please. It sounds like something with milk. And what they do is they insert this sling made out of either artificial tissue or it can be made out of somewhere fascia from the body. And they slip it through they attach it to the lid. They push it through underneath the skin. They sew it up there. So now the frontalis muscle is responsible for opening up the eye. It's not the levator, but the frontalis muscle is responsible for opening up the eye. It can be a synthetic material, so silicone or collagen from the thigh area, and tutoplast it's an allograft. It's sterilized with gamma radiation, and it transfers the elevation of the lid to the frontalis muscle. And here's what she looked like in 2009. She still has scarring, however, she's functioning much better than she did, and she still has pretty big scarring over here, but she's able to close her eye. And this is 2010. Once again, she's having another surgical procedure to repair that cosmetic procedure as well. This is what her cornea looks like as well, because she doesn't have full coverage and full ability to blink and to wet her cornea. And this is, once again, she says, scarring in that area there. A 44-year-old male came in.